a neurologist here in Swansea, and I've been working with sale data for a few years now. I mainly to try and answer some clinical questions. So in this talk, we'll talk about three different neurological conditions and trying to illustrate some of the points that come across when and are important to consider really when you're using data within sale. So what you'll see here, I'm not sure if you're familiar with these pictures, these red circles are your optic discs. So when you go to Specsavers and they have that bright light passing in front of you, that's what people will see. And as you're looking at the screen, the one on the right, you'll see a kind of yellow circle, which is your optic disc. That's where the optic disc connects with your retina. And then the one on the left, you see that's the same place is not a clear yellow circle. It's a kind of volcano kind of poking out a bit. And that's because the pressure in the spinal fluid has increased so that it's pushing at the optic disc. And this can happen in this first condition I'm going to talk about, idiopathic intracranial hypertension. So idiopathic means just happens intracranial in the head, and hypertension, raised pressure. So if you get this condition, the pressure of your spinal fluid increases. And it can threaten your vision because of this pressure on the optic nerve. So we set about to look at this condition. And the first thing we looked at was we tried to see what was the best way to find these cases within sale. So within Swansea, we had a list, a registry of people that we definitely knew had the condition, which is about 153. And then we were able to link those to sale in the normal way, which I'm sure you're all familiar with, the split file approach. And I think this is a really useful thing to consider when you're looking at perhaps conditions that haven't been studied before, or you want to get an idea of how accurately things are coded within sale. So we could link that registry data with the other data within sale, and then you could get an idea of how many of those cases which we definitely knew had IAH had specific codes within the routinely collected data. So you can get an idea of how sensitive your algorithm for getting cases is. And most of the time, as Valentina said, diagnosis clinically are fine, but you can be caught out sometimes. So how this was useful to us, just to illustrate a point, there's a very similar but quite different condition called idiopathic intracranial hypotension. So instead of the pressure being too high, the pressure's too low, hypo, as opposed to hyper. And what we found is that quite a significant minority of these cases have the wrong code in primary care. So I think, if you're in primary care dealing with rare conditions, you can easily, in a short appointment, see how IIH, hypotension is selected instead of hypertension. So this kind of approach where you link the sort of gold standard cases within sale, we found very useful for checking that your case ascertainment algorithms are accurate. And so once we did that, we got an algorithm that we thought was pretty sensitive. And you can see with a sort of capture, recapture thing, using different combinations of codes from different places. For example, here from GP read codes and ICD-10 codes from hospital codes increases your sensitivity from about 85 to about 92%. And this is what we found really. So we looked at the prevalence, the proportion is on the top graph there, the proportion of people with IIH over time. And you can see that's increased. And also you can see that the incidence, the proportion of new cases has increased, more perhaps in women than men as well, as this condition is predominantly affects women. About 80% of cases affect females. And there is a link with obesity as well. It is a risk factor for IIH. And you can see from SAIL, which again is something quite useful. We looked at BMIs from recorded in GP and compared them with this questionnaire data, the green data. And there has been a trend for increasing rates of obesity in Wales, which is important. We also can see here on the top graph the prevalence of IIH looking at deprivation. So you've got your WIMD quintiles, which we're familiar with, where one is the most deprived quintile. And you see there's far higher proportions of IIH in the more deprived areas in women, but not in men. So there might be something potentially that affects female more in deprived areas, which is quite interesting. And then you can see the link between obesity and deprivation, more obesity, more deprived areas. But the link between IIH and deprivation is not just because of obesity, because we were able to adjust for that. And in an adjusted odds ratio, even when you take BMI into account, you can see there's a significantly decreased risk if you live in less deprived areas. So a link between deprivation and IIH, even when you adjust for obesity, which I think was quite a new significant finding. And the other good thing about SAIL, as we know, is that we can look at healthcare utilization, and this is quite important for healthcare planners, and it also tells you a lot about what's going on. So you can see here that on the horizontal axis is the time when people were diagnosed, so 0 is the time of diagnosis, and on the vertical axis is the the rate of hospital attendances. As you'd expect, there's a big spike around the time of diagnosis, but perhaps more interesting, if you look at the green and the blue lines, the people with IIH, there's certainly more hospital utilization rates before and after the diagnosis. So perhaps some signals there that something is going on before the diagnosis happens. And the blue line are people who've had surgery for their condition, had a shunt put in, and not unexpectedly, they have more hospitalization rates. And with the rise of injectable treatment now, the GLP agonists for obesity, the information that we had from this study has been used in government policy for prescribing these drugs, and IIH has become a priority for using these drugs on the NHS, which has been useful. Got the paper published a few years ago now, but interestingly, we got this very high ranking, high impact factor journal interested as well, which has got advantages and disadvantages. So moving on to another neurological condition. So this is epilepsy, and these images is on the left. This is someone with epilepsy who's drawn what they think of when they think of the seizure. And the same with the image on the right. This is someone drawn an image of his brother who has epilepsy. And epilepsy, you might be familiar with this condition where you have tendency to have seizures, where seizures are electrical disturbances in your brain. And the seizures can cause all kinds of problems, including this unpredictability. You're never quite sure when your next seizure is going to happen. And it's quite common. So, it affects about 1% of the population, about 30,000 people in Wales. So we tried to look quite a bit at epilepsy in SAIL. And as Valentina alluded to earlier, this type of information you're seeing now is what we sort of think about when we see someone in clinic. We want to know what type of epilepsy they have, how many seizures they're having, the types of seizures, the medication they're on, the MRI results, and the medication that they have been on. But this is the kind of equivalent thing you will see in SAIL. So you just might see a code for epilepsy and you might see a code for the drugs. But there's a lot of information lost in routinely collected data. And getting this extra resolution has been one of our projects over the last few years. And this is how we've chosen to do it. This is a typical sort of clinic letter. So if you go and see your specialist in a hospital for your epilepsy, they might send you a letter, or your GP back with a letter like this. And this is a synthetic letter. It's been made up, but it looks very similar to what you would get. And you can see straight away that there's lots of useful things for research here. So it confirms the diagnosis, and the green things are what seizure types. You've got an EEG, which is a type of investigation. You've got the results in there. You've got the frequency of the seizures, and the medications that have been tried in the past, and medications that you're on now. So what we try to do is try to get that information out to the clinic letters and into SAIL to increase the resolution of the data. And we've developed a natural language processing system, which is rules-based, but it works pretty well. And what we've done, so we've taken all neurology clinic letters within a 10-year period in Swansea Bay. We've put it through the natural language processing system, and we can get quite detailed information about 8,000 people with epilepsy. So not far off a third of the people in Wales with epilepsy. And as you can see, these in the table here is how accurate the system is, exact compared with a human of doing the same thing. And even though the exact system is not perfect, it's probably slightly better than a human. And, you can imagine why. If you give 280,000 letters for a human to read, you can see that they might make mistakes, even if they're the most expert at epilepsy in the world. And so getting this detailed epilepsy information out from the clinic letters into SAIL is really useful, and we can do lots of things, and we're hopefully starting to do lots of things with this. And this is how we see it works. So the clinic letters stay within the NHS. They've got lots of personal and identifiable information on them, and they're also unstructured. But you can run those letters through the NLP system and draw out structured epilepsy information, and then also draw out the identifiable information in the normal way. And then you can put that in SAIL and link it with the other information as usual, and leave in then for future use a more detailed data set. So that's our aim, and we're in the process of creating this epilepsy research cohort, which can be used in future. And as Lewis said, the aim would be for this to be a more federated system across all health boards in Wales. So you'd leave the NLP software within each health board, and then they'd upload the anonymized structured data into the epilepsy research cohort regularly. And this is an example, a very recent example of how we've been able to use this detailed information to notch up, bring the level of research up a bit. So before this, we could only say if someone had epilepsy or not. And now we've been able to subgroup the epilepsy into these different types. And there's lots of different causes for why you might have epilepsy. And this is Catherine Bush's work in Newcastle, who's been looking at this. And you'll see in the different age groups, the different types. And interestingly, the blue chunk here, potentially preventable etiologies. And as dementia can be preventable, so can epilepsy. And no one's really thought about this before. So this is the exciting thing coming out here. And just to finish with a third condition. So this is an old illustration. I'm not sure how well it comes across, sorry, but you can see a person there, and they're quite sort of contorted and twisted, and they're having a seizure. But they're not having an epileptic seizure. They're having something which looks very similar to an epileptic seizure, a functional seizure or a dissociative seizure. And people with these seizures are affected by many of the issues that people with epilepsy have. They have these unpredictable episodes where they lose awareness or consciousness. But the seizures are caused by a different mechanism. So they're not caused by the electrical disturbances you see in your brain in epileptic seizures, but they're caused by the brain sort of losing control or disassociating for a period. And no one's really, to my knowledge, studied these within routinely collected data in the UK. And more rare than epilepsy, but perhaps not as rare as IIH. And as we did with the other studies, the first thing we did when we started this project was to really work out how are we going to find people with functional seizures in routinely collected data in SAIL. It's harder, it's not as well coded, and we know that as clinicians, when we diagnose this condition, it's misdiagnosed as epilepsy frequently. So this was a harder process. But using a similar thing to before, where we uploaded definite cases within SAIL, we have come up with an ascertainment algorithm using primary and hostile data. And again, we've looked at healthcare utilization, which is important for planning healthcare and important to try and understand things. And again, we've looked at these, the greens here are controls, the orange line are people with epilepsy, similar but different condition. The pink line are people with the functional seizures, and the blue line are with both. And a few interesting things here. Again, you'll see the signal before the diagnosis that something's going on. There's increased healthcare utilization. And you'll notice the difference after the diagnosis. People with epilepsy, their healthcare utilization seems to go down, whereas the people with functional seizures, it stays high and increases. And there's something going on with the people with both conditions. It does introduce a lot more complexity and difficulty in diagnosis. And you can see that quite clearly here from the healthcare utilization. And finally, I'll leave you with, again, some work on these, on the functional seizure. If you look at the graph on the left, what we're doing here is we're combining census data with the SAIL data, which again, I think is a fantastic thing within SAIL, and you know, gives SAIL quite a unique position to use the census data, because now you can use individual levels of deprivation as opposed to the area-based markers of deprivation within the WIM score. So on the left, you'll see that there's perhaps not much difference between controls, which is 1, the odds relative risk of 1 going up, and the people with epilepsy, people with FTS, functional seizures, and both. But you see there's quite a big difference if you look at the census category of being long-term sick. And if anything, people with functional seizures seem to do worse here than people with epilepsy for being on a long-term sick position. So still analysing this data, and I think the census data is really interesting and answering a lot of the criticisms that people have with just using an area-based measure of deprivation. So there we are. So I've talked about 3 neurological conditions: the IIH, idiopathic intracranial hypertension, epilepsy, and functional seizures. We talked a bit about how you can check how accurate diagnoses are if you upload your own registry data. Talked a bit about getting that extra data in SAIL, and one way of that, getting that extra data is to use natural language in processing, and also how advantageous using census data can be within SAIL to answer certain questions. Thanks to all the team who've done the work here, and yeah, I'm happy to take any questions. Thanks.